Mr. Gordon Lim is a physiotherapist, senior physiotherapist from AEVI Sports and Physio Clinic. So he graduated from Singapore Institute of Technology with a degree in physiotherapy in 2018 and is fully registered with the AHPC. So he had worked in a restructured hospital for 3 years and has garnered much experience dealing with patients with neurological, cardiopulmonary, and musculoskeletal conditions, as well as post-surgical orthopedic patients. So he's a strong advocate in empowering his patients through exercises and hope to manage them better in their conditions through education. And outside of clinical work, he is also an avid marathon runner, completed the 2019 Southeast Asia Games in Philippines. And he's still training competitively while doing his physiotherapy work. So without further ado, I would actually like to hand over to Gordon to kick off today's webinar. Gordon, please.
Hello, hi. Just give me a second, okay? And then I'll share the slides. Okay. Can everyone see the slides?
Yep, looks good.
Yep.
Okay, and so I'm going to begin. So hi everyone, Gordon here. So today I'll be presenting on sports-related hip and groin injuries. We will be going through some anatomy of the hip as well as some risk factors. Then I'll talk about some physiotherapy assessments that we can do for such injuries. Then we will also go through 4 conditions that we commonly see in the clinic and how we can assess and manage them. So without delaying, I'll begin. So firstly, I'll talk about the anatomy of the hip. It is a ball and socket joint, comprised mainly of 2 bones, the femur and the pelvis. The ball is formed by the femoral head, while the socket is formed by the acetabulum. So the primary function of the hip, right, is to support the weight of the body and facilitate load transmission. The hip joint possesses greater intrinsic bony stability than any other joint. And there are also nerve fibers within the joints that provides proprioception and nociception. So what other structures add stability to the hip? It is also supported by ligaments such as the iliofemoral ligament, pubofemoral ligament, and ischiofemoral ligament. The labrum also deepens the acetabulum socket and further enhances the hip joint stability by maintaining negative intra-articular pressure. So there are generally 6 movements of the hip, right? Flexion, extension, abduction, adduction, external rotation, and internal rotation. So these are some risk factors for hip and groin pain, and we can usually divide them into modifiable as well as non-modifiable risk factors. As you can see here, modifiable risk factors include, but are definitely not limited to, the weight of the person, the type of sport the person participates in, potentially the range of motion of the hip, as well as the strength of the surrounding muscles. Now, non-modifiable risk factors would be the age of the individual, any prior hip or groin injuries, as well as the morphology of the hip. What we do know, however, is that these risk factors are not entirely absolute. So we found that some papers found that a measure of hip range of motion of a total of less than 85 degrees of external rotation plus internal rotation have shown to increase the risk of hip injuries. However, those studies not take into account probably sport-specific sort of adaptations that may have resulted in the athlete having a little bit more limited range of motion. So if we follow this strictly, then we might be overly conservative when picking up athletes at risk. So the next is with regards to strength, right? Tyler et al. 2001 found that a hip abduction to abduction strength ratio of less than 80% was also predictive of future hip injury risk in professional hockey players. We can't say for sure that this applies to other sports, but we can probably use this sort of data when we are maybe seeing professional hockey players. So next, sports that involve many rotational movements and trauma, such as rugby, ice hockey, and soccer, can potentially also increase the risk of hip injury. Other sports, such as dance, gymnastics, and martial arts, can also cause hip injuries due to the nature of the movements, which continuously challenge the functional limitations and the range of motion of the hip. These are some of the common injuries to the hip and groin region. So as you can see here, these injuries are usually subdivided into at least two groups. We will go through the highlighted conditions later on during this presentation also. So firstly, we'll be talking about femoral acetabular impingement. It's FAI for short. It's a motion-related condition of the hip involving premature contact between the acetabular and proximal femur. Next, we will look into adductor strains. Patients usually present with pain in the inner thigh and tenderness on palpation along the muscle, tendon, or insertion point. Then we will look at gluteal tendinopathy, which is also defined as pain over the greater trochanter. It is usually accompanied with tenderness over the greater trochanter, and occasionally this pain can also radiate down the outside of the thigh. And lastly, we will talk about snapping hip syndrome, which is characterized by a snapping sensation around the hip when it is moving. So a visit to the physiotherapist usually, consists of many questions, right? Subjective questions and also some objective assessments. So some simple questions would be, we might want to know that what's the mechanism of injury, a 24-hour pattern of the patient's complaint, the aggravating factors, easing factors, and potentially some other biopsychosocial factors, maybe, never sleep enough or stress levels too high. This list is definitely non-exhaustive lah. Next, we will look at objective assessments. We will be observing for maybe, we will observe for swelling and redness, if any. We will also check and clear adjacent joints. In pertaining to the hip especially, we might consider, any referred pain from the lower back as well. We also look through range of motion, strength of surrounding muscles, and occasionally we will also use some orthopedic tests to help guide our diagnosis and then our treatment. So what are some of the common injuries to the hip? We will first talk about FAI. As mentioned earlier, FAI is a motion-related condition of the hip involving premature contact between the acetabular and the proximal femur, which may result in some symptoms. There are generally two types of impingement, known as the cam and pincer morphology. In some cases, there is also a combination of these two types of impingement. So studies by Ravindran et al. 2018 have also found cam morphology is more common in men, while pincer morphology is more common in women. And based on the Warwick Agreement 2016, a triad of symptoms, clinical findings, and imaging findings are required for the diagnosis of FAI. It is important that we know that it is diagnosed when there is a combination, because if you only depend on imaging findings, it might not be accurate. And this is because there are studies such as Register et al. That found that MRIs of 73% of asymptomatic patients revealed abnormalities. So labral tests were found in as many as 69% of these patients. There are also many other similar studies that show abnormal hip imaging findings in asymptomatic patients. Hence, a triad of symptoms, clinical findings, and imaging findings is important in the diagnosis of FAI. So what are some of the risk factors of developing FAI? So according to authors Chaudhry and AEVI, they found that other risk factors include, genetics, repetitive athletic activity, prior hip surgery, in individuals who participate a lot in sports that involve vigorous flexion and rotation during their younger years. This especially so if they compete about 3 times a week, considering both competition and training days. They do have an increased risk of developing FAI. So another study by Canetti et al. Also found that some occupations may increase the risk of individuals developing FAI. It is more common in occupations involving cumulative and repetitive overloads, such as professional sport like soccer and hockey, as well as military personnel. Of course, workers with a history of high-level sport or physical activity participation are at a higher risk of developing FAI. So when it comes to physiotherapy assessments for FAI, we might find the following subjective and objective assessment. Firstly, subjective assessments for FAI may reveal maybe clicking or catching sensations, right? A possible complaint of locking or giving way, possible complaints of pain during acceleration and deceleration movements, as well as complaints of pain in deep squatting, climbing stairs, and prolonged sitting. Objective assessments may also reveal a reduction in range of motion of the hip, as well as a positive fader, which stands for flexion, adduction, internal rotation test, as seen in the pictures over here. So with regards to physiotherapy treatment of FAI, we can consider education and advice, especially regarding exercise activity modification in the early stages at least. Other physiotherapy options such as manual therapy, using EPAs, electronic physical agents, can also be performed to the specific needs of the patient. So most importantly, there is also evidence regarding conservative management, which involves hip-specific and lower limb strengthening exercises according to our assessment findings. Sorry. We can encourage patients with FAI to perform exercises that work on their problem list. For example, the patient may have difficulty sitting on a low stool due to pain in the hip. We can encourage them to first build strength and confidence through sit to stand movements from a higher stool or higher level. Thereafter, we can also change the placement of the foot to bias the affected side to slowly expose more load into the side that is affected, as seen in the first two pictures on the left. Exercises are non-exhaustive in nature, and we can always tailor the exercises according to our patient's complaint as well. Okay. The next condition we are talking about is gluteal tendinopathy. The condition is believed to be the primary source of lateral hip pain. In people with lateral hip pain, the thickening, thinning, as well as tears in the gluteus medius and minimus tendons have been observed on ultrasound and MRI scans. So this condition was also previously known as trochanteric bursitis. Okay. Occasionally, this condition can also result in pain radiating down the lateral thigh. There are many studies that looked into the common causes as well as risk factors of gluteal tendinopathy. Loquesti et al. 2008 and Rompe et al. 2009 found that it is more commonly reported in individuals above the age of 40. Depending on which study, there's also an increase in incidence of this condition in women compared to men, with a ratio of 2.4 to 4:1. I'm so sorry. Okay, so also mentioned, Grimaldi et al. 2015 also mentioned that common causes of gluteal tendinopathy includes repetitive activities such as running, jumping, training errors which involve excessive overload on the tendons and muscles over a short period of time can also cause gluteal tendinopathy. Weakness in the hip abductor muscles can also contribute to increased compression at the gluteal tendon. So the development of gluteal tendinopathy is similar to other insertional tendinopathies, which is overload or compression of the tendon at the bony insertional points. So this clinical documentary by Grimaldi and Ferren also spoke about pathomechanics of gluteal tendinopathy and divided them into 3 different causes. The first one is a joint position cause that results in more stress over the gluteal tendon. The IT band causes a compressive force on the gluteal tendon when the hip moves into an adducted position. Repeated hip adduction movements, especially in single leg weight-bearing exercise activities, can put more stress on the gluteal tendon, potentially resulting in tendinopathy. The second is the lack of muscle force to absorb load. In a single leg stance position, 70% of the load is usually absorbed by the hip abductors, while 30% is absorbed by the iliotibial band. However, weakness of the hip abductors can transfer more stress to the IT band and result in an increase in hip adduction, leading to higher compressive forces at the greater trochanter. And thirdly, bony factors can also create more compressive forces on the gluteal tendons. As you can see in the diagram here, a lower femoral neck shaft angle can increase tension of the iliotibial band on the gluteal tendons, causing irritation. The clinical commentary by Grimaldi and Ferren, did the same paper, also propose load management and exercise therapy for gluteal tendinopathy. For load management, they propose avoiding hip abduction positions in ADLs, activities of daily living, such as standing and sitting. You can see in the diagram here, these are positions that you can suggest to patients to kind of avoid for a bit. We can also suggest nighttime positions, such as sleeping positions, that put little to no compression on the gluteal tendon using some pillows. And we also advise them to control some high tensile loads. Education regarding activity modification can be helpful for patients with gluteal tendinopathy. For example, for the older and deconditioned patients, we may suggest to minimize hills and stairs, as well as titrate their walking distances. My bad. For the athlete, temporary suspension from long distance running may be needed. Cutting down on tempo and hill running, as well as plyometric activities, may also be advised. So a physiotherapy assessment for the suspicion of gluteal tendinopathy is definitely different from what we previously talked about, the FAI. So for our subjective assessment, right, we might be looking for complaints such as, lateral hip pain with tenderness over the greater trochanter. The patient might also complain of pain at night when lying on the painful side. They might also complain of pain when going up high steps, as well as discomfort during prolonged sitting or sitting with the legs crossed. Objectively, apart from strength, range, as well as tenderness and palpation, we can also perform following tests for gluteal tendinopathy. First, we can perform the Fader R test, where we will be bringing the patient into a flexion, adducted, and external rotation position. Thereafter, we will apply resistance and get the patient to perform an internal rotation movement of the hip against our resistance. Next, we can also conduct a single leg balance test, testing for either or both duration and pain. We will do this by getting the patient to be on a single leg stance position for about 30 seconds, and we will be looking out for pain and potentially a hip drop as well that can indicate weakness. Next, we can also perform a modified Ober's test to challenge the gluteal tendon by compression. Apart from load management strategies, as previously mentioned, exercise therapy is key for patients with gluteal tendinopathy. So isometric exercises can be slowly introduced. It is a common way of managing tendon-related pain. Sustained low-intensity contractions can be used, such as the hip abductors, can be effective in raising pain pressure thresholds in patients with gluteal tendinopathy. These are some simple non-weight bearing exercises that we can perform in isometric manners. We can also add an ankle weight to make the exercise a bit more challenging. So once isometric exercises are completed and patients are able to cope with more load, we can then introduce low velocity, high tensile load exercises. The aim is to achieve hypertrophy of the muscles. And in this particular case, we might focus on the gluteus, medius, and minimus. Weight-bearing exercises can also stimulate higher levels of muscle activation. As patients may be coming back from injury, a 24-hour load monitoring approach can be used to observe the tendon response to exercises. So these are simple exercises that target the hip abductors, which can help with the treatment of gluteal tendinopathy. Okay. We will now move on to the most common hip and groin injury, the adductor muscle related injury, right? So they are the most common, especially in professional soccer players. And according to Ekstrand et al., the injury rate is about 0.6 per 1,000 exposure hours. And of course, Cerner et al. 2018 also found that adductor-related injuries account for up to 63% of hip and groin injuries and 23% of all muscle injuries. So common causes of adductor-related injuries are repetitive kicking motions, changes in direction with the load of the body and the trunk on one leg, reaching and stretching movements, as well as sprinting actions. So other risk factors for adductor-related injuries include a history of groin injuries, as well as a reduced abductor to abductor strength ratio. According to Griffin et al., who looked at uninjured Premier League Academy soccer players, They suggested that the adductor to abductor strength ratio on the dominant leg should be 1.45 to 1.6, while on the non-dominant leg it's a bit lesser lah, so 1.25 to 1.45. So physiotherapy assessments for adductor-related pain includes finding out the mechanism of injury on top of the usual subjective questions. So objective assessments when suspecting an adductor-related injury includes performing a squeeze test, observing for tenderness on palpation, performing a strength test to the adductors and abductors. When treating adductor-related injuries, there is evidence that exercise therapy can help with the treatment of adductor-related pain in athletes. So Homing et al. Found that a concentrated strengthening approach that targets the coordination and strength of the muscles, stabilizing the pelvis and the hip joints, in particular the adductor muscles, can bring better results at reducing pain and returning to sporting activity at the end of 4 months. This is in comparison to another program that just involved laser treatment, massage, stretching exercises, as well as electrical nerve stimulation. At the end of 4 months, it was found that, in the active training group, 23 athletes actually went back to the sport without groin pain. So these are some of the exercises in the active training group. Module 1 on the left was performed for the first 2 weeks, followed by module 2 from the 3rd week onwards. We can consider using these guidelines as rehabilitation for patients with adductor-related injuries. However, despite these studies being done, the re-injury rate for adductor-related injuries remain high. So what else could be done, right? We found a study that looked at criteria-based sort of sports rehab. So Andreas Ferner and his colleagues looked into it and found out that if having one helps with lowering re-injury rates. They found that male participants who met a clinical criteria, also known as sort of like a clinically pain-free criteria, had significantly lower risk of re-injuries than athletes who did not meet the criteria. This was the clinically pain-free criteria. With such studies being done, we may be able to use such criteria when treating patients with adductor strains and to determine if they are ready to return to low levels of sports participation. Some physiotherapy exercises that we can encourage patients to do are the side-lying hip adduction exercise. And once they feel much better, more confident, less painful, we can then get them to perform more difficult exercises, such as the Copenhagen adduction exercise. Lastly, the condition we will be mentioning about is snapping hip syndrome. This condition is characterized by a snapping sensation around the hip when the hip is in motion. There are 2 main causes of snapping hip syndrome. The first is the external snapping hip syndrome, which happens when the iliotibial band or gluteus maximus goes over the greater trochanter of the femur during movements of the hip. The next is internal snapping hip syndrome, also known as dancer's hip. This happens when the iliopsoas tendon, which is the tendon of our hip flexors, is snapping over a bony prominence of the pelvis. It is important to note, though, that snapping hip syndrome can be pain-free. Bird et al. 2006 found that snapping hip happens to about 10% of the population. It may be higher in other selected populations, in particular athletes who may require extreme hip range of motion, such as soccer players, hockey players, some runners, and some weightlifters. According to Winston et al. 2006, they also found that 90% of ballet dancers report a snap, a crack, or dislocation sensation during certain movements that involve hip abduction and external rotation. According to Lewis 2010, right, they found that gender is not a risk factor when it comes to snapping hip syndrome, although there are other studies that show that it's more common in women than men. Snapping hip syndrome is typically an overuse injury with a higher occurrence in activities that involve repetitive flexion and extension. These movements are commonly performed, like I said, in dance, soccer, gymnastics, as well as running. A physiotherapy assessment of snapping hip syndrome consists of some questions. What we may note is that for many snapping hip syndrome cases, the patient may present as pain-free. Apart from the usual mechanism of injury, as well as aggravating factors, we would also like to know prevalence and frequency of the snap, the location of the snap, the timing of the snap, as well as the impact that the snap has on the individual's activities of daily living. Objective assessment will also include, for the suspicion of external hip syndrome, the OBUS test, a side-lying flexion extension test. A Faber test can also be used. For the suspicion of internal snapping hip syndrome, the Thomas test and iliopsoas stress test can be used. To further elaborate, a side-lying flexion extension test is performed by placing the patient side-lying on the unaffected side, with the affected hip held in adduction. Keeping the knee in extension, the hip is then actively flexed and extended. The IT band will be felt flicking over the greater trochanter. When it comes to physiotherapy management of patients with pain-free snapping hip syndrome, Dr. Thomas Bird mentioned in his paper that for most patients, the treatment is then little more than assurance that this is a normal variant and that the snapping is not indicative of future problems. Activity modification for aggravating activities can be one of the first things we will want to do as physios. We can help them to modify the activity, right? So we may not need to discontinue activities that we have been doing. However, the exercises will need to be tolerable enough to avoid acute flare-ups on a regular basis. In this diagram here, we are citing examples of a distance runner who may be having a case of a painful snapping hip. We can suggest changing the intensity of the exercise, the complexity of the exercise, in this case, flat ground running instead of trail or hill running, as well as time spent on exercising. In this case, lowering the duration of running, as well as the number of running sessions. We can also change the exercise variables for other patients as well. So, for example, the patients find it difficult to perform an exercise with full range of motion, we can get them into partial range of motion. If that patient finds it difficult to perform an exercise quickly, you can do it slowly. And if the patient finds that with resistance bands and with weights, exercise is more difficult and also uncomfortable, you can take those things off as well. Regarding physiotherapy treatments for snapping hip syndrome, we can deal with internal snapping hip and external snapping hip slightly differently. For internal snapping hip, our focus will be on training the hip flexors through as much range of motion as possible. We have two examples here, supine straight leg raise as well as standing hip flexion with resistance band. For external snapping hip syndrome, our focus should be on training the gluteal muscles in different positions. One such example would be a hip thrust, right? So if let's say a single leg hip thrust is too difficult, they can always do a double leg hip thrust before progressing back to a single leg hip thrust. With that, I think I am done. Thank you for listening.
Yeah, so I will move on to the next segment of this webinar. So we have Dr. Joshua Lee, who happened to be speaking to you earlier in the webinar. So he's a great colleague of mine at Changi General Hospital. He's currently an associate consultant in sport and exercise medicine. And he graduated from NUS Yong Liu Lin School of Medicine in 2011, obtaining his NMed in 2018, and then completed his specialist training in 2022. So he's practicing at 3 places, at Changi General Hospital, SGH, as well as Singapore Sport Institute. And his clinical interest very obviously lies in endurance sport, and he's a triathlete himself. And he has a finesse and interest in ultrasound-guided injection therapies as well. So he's currently one of the EXCO members in SMAS, and he also provides medical covers for the various sports events in Asia Games, in SEA Games, and is also helping out in Formula One
Hello,
and the Premier League. Yeah.
I think quite straightforward, I saw.
So what happens is that he is also an athlete, and he's in the national triathlon team, and he's a competitive marathoner runner in all forms of running. So without further ado, I will hand over the stage over to Joshua.
Thanks, Victor, for the kind introduction. Just want to check if you can hear me.
Yes.
Okay. Yeah. Hi, everyone. Just thanks again to Curry Sweat, our official hydration partner. The support from Curry Sweat actually helps to keep the webinars such as this free for everyone. So a big thank you to them once again. All right. So again, just a reminder, if anyone has any questions along the way, we will have a Q&A at panel last 15 minutes or so where the three of us will answer your questions. So if you have any questions along the way, please write them in the chat. Okay, so today my talk, I'm going to talk about groin injury. So if you notice, we started off with Gordon, our physiotherapist colleague, talking about in general hip injuries, right? And he did touch on the most common groin injury, which is adductor strain, right? Adductor tendinopathy. So I'm going to talk a bit more on groin injuries with a deep dive into this entity called athletic pubalgia, right? So these are my contents for today. So I'm just going to go through some of the other differentials for groin pain and going through what groin pain can be and cannot be, and what other things besides the musculoskeletal system, MSK system, can be involved. When we talk about pain in that region, and then talking more into sports hernia or athletic pubalgia, talking about terminology, anatomy, and all the way down to the investigations and management. Okay, so today's topic, this whole webinar is about hip and groin injuries, right? So, admittedly, the hip and groin injuries are not as common, do not feature as commonly as the knee injuries to the knee and to the ankle. However, when patients do come with hip or groin pain, sometimes the diagnosis to the clinician may be a bit challenging because there are many, many differentials as we will go through and we will see. And a lot of the pain may not be so well localized, right? Part of it is because the hip joint is very deep, not very easily palpable, as opposed to things like the knee joint, or the ankle joint, right? As Gordon went through previously, hip pain is mainly can be divided mainly into intra-articular or extra-articular, means within the joint or outside the joint, right? But groin pain, you will find that's actually more extra-articular, outside of the hip joint, and we will talk about that. Okay. So I've listed this long list here of hip pain just to demonstrate, right? Or just to show that actually there are many, many different differentials when we are talking about the hip, right? Both intra-articular inside the joint and extra-articular. And my colleague and Gordon has already gone through FAI, right? As well as some of the snapping hip syndrome, both internal, external snapping hip. Yeah, and we not to mention also gluteal tendinopathy. So this is just to highlight that there's a wide range of differentials. I'm not going to go through each one of them, of course. But then when you have if we have excluded the hip joint, right, both intra and extra articular as a cause for pain, when we come down to groin pain per se, and this is just talking about the pain in the groin, there are so many other differentials that we need to consider that are non-musculoskeletal, right? So the pain may come from inside the abdomen, so intra-abdominal, right? So we're talking about hernias, both femoral and inguinal hernias. It can be appendicitis, diverticulosis, and so on and so forth, right? And even involving the intestines. What else is in the region? Let's not forget also the genitourinary system, and that's what we're talking about in terms of the gynae organs. So whether is it the ovarian cyst, right, the torsion of the annexal organs, pelvic inflammatory disease, endometriosis, right, and what's also in that region is also the urological system, right? Talking about the kidneys, the bladders, the ureter. So kidney stones, prostate inflammation, the testes in males, right? So torsion, all these can actually present as groin pain. So really a whole wide range of differentials that the clinician has to think about or keep at the back of his mind when he presents with an athlete with groin pain. Okay. And so now we come to the subject matter per se. And after we have kept all the other differentials at the back of our mind, and we go straight into the four main so-called entities of groin pain based on the Doha classification or agreement, we have a few regions, right? So Gordon has actually gone through the most common one, number one here in blue, which is the adductor-related pain, adductor tendinopathy. Right. The second most common one is actually from the hip flexors, right? So this hip flexor called the iliopsoas. right? So groin pain can also be due to the strain from the hip flexors, whether it's weakness or tightness, and so on and so forth. Today, in today's star, what we're going to talk about is actually this third one, right, highlighted in purple, which is more towards the inguinal-related kind of groin pain. Right, and here you can see where it is in blue, right? And here in yellow, the fourth one is the pubic related or osteitis pubis, which is also closely related to athletic pubalgia, and what we will also cover that briefly today. Okay, so when we talk about terms and athletic pubalgia, AP, right, it's a quite a mouthful, right? You will find in literature that this entity or this syndrome has actually many names, right? So I've been calling it athletic pubalgia. It's also known as pubalgia athletica. Talk about sports hernia, sportsman hernia, sportsman groin, sports-related groin pain, and then some other associated sports names start to come in, right? Hockey groin, footballer groin, Gilmore's groin, and the list goes on, right? So we need to be aware when we start to read, especially some of the older literature, when they are talking about these different things that they kind of talking about the same thing. But for today, there's no consensus as to what to call it exactly, but athletic pubalgia seems to be gaining traction together with things like sports hernia, right? Sports hernia on its own is a bit of a misnomer, meaning that isn't actually a hernia per se, right? So some experts have said that sports hernia, because it's misnomer, we should avoid calling it a sports hernia or sportsman hernia just because it's really not a hernia. Okay, so we did dive into anatomy, and this is crucial to understanding the cause of the pain and the mechanism of injury, right? So let's go through this, right? We have this entity called the conjoint tendon, which I have boxed up here in red, right? We know that the abdominal wall is made of 3 layers, right? The external oblique, internal oblique, and the transverse abdominis. So the deeper 2 layers, which is the transverse abdominis and the internal obliques, actually converge. Here you can see highlighted in green to form this conjoint tendon, right, over here at the back. As it goes down, it forms the inguinal ligament as it combines with the most superficial layer, which is the external oblique, right? So the external oblique plus the conjoint tendon actually combine to form the inguinal ligament. Hence, the main issue here is this portion, right? So the inguinal ligament as well as the conjoint tendon, there is some tears or injury to this region causing the inguinal related kind of groin pain. Okay, that's above the pubic bone. Yeah, let's look at below here. So the adductor longus, which is one of the adductor tendons, this is the muscle, and this is the tendon. The tendon, the anterior portion, actually crosses the front of the symphysis, which is this bone in the front, right, and to fuse with this portion, which is what we talk about, the conjoint tendon, inguinal ligament, and also a bit of the abs, the lower abs, so rectus abdominis. We talk about the 6-pack, right? So the rectus abdominis, this part, the insertion over here, and you can see actually it forms what we call aponeurosis, or a bit like a fibrous web, if you may, right? A covering that combines the adductor longus tendon, right? The rectus abdominis insertion, as well as the inguinal ligament. So a bit like a 5-pointed star. All right. So these aponeurosis fibers, which insert from both the adductors here and from the rectus above, they insert directly into the pubic symphysis, which is a joint right here in the center, right? The joint capsule and the disc, right? So therein lies the problem, right? So many muscles and so many structures all inserting into one, right? And hence, there is actually that represents a place of weakness, if you may, right? Or a place where there are a lot of forces acting towards it, right? So here in this diagram, you can see that actually at this region, there are many forces pulling in different directions, right? You have the abs pulling upwards, right, diagonally, and as well as the adductors pulling it downwards, right? So forming this kind of like a cross brace over the symphysis, right, where you have the abdominal muscles, the vectors over here, and adductor muscles vectors over here, pulling all here. And we talk about that 5-star kind of diagram around over here. So, right, so the rectus abdominis, right, the inguinal ligaments at the oblique muscles as well as the adductors over here. So a lot of possible weakness over that region, right? So what is the etiology? What causes this injury, right? So this entity called sports hernia, athletic pubalgia, is a chronic repetitive overuse injury to this part of the groin, the musculotendinous part of the groin, which involves the lower abdominal muscles, as we mentioned, the rectus abdominis here, as well as the upper thigh muscles, which is the hip adductors here. We know that it's more common in males than females, right? And one of the reasons is that because the pelvis, the female pelvis anatomy is this angle is a bit wider, has a larger what we call suprapubic angle, and so you can better guide the forces away from the pubic region, as opposed to a more acute angle here in males, which means that they actually more forces are actually directed at this region. Okay. So what are the at-risk biomechanics? Gordon has already alluded to some of the types of sports that are at risk, right? But basically what these sports have in common is that they move forcefully from a front-leaning position, or what we call the standard athletic stance, into an extension of the trunk, bending backwards, or adduction of the hip, right? So they lean forward and then they suddenly extend their trunk, right? Or they have this high-speed sudden change of movement, change of direction, like when they are turning or when they're cutting, right? The spot, or when they're kicking, or what we call the and that is biomechanics, we're talking of the groin, right? Or rapid acceleration or rapid deceleration, as in sprinting, right? So you can see here in this picture of a footballer where they start off as they're trying to kick, right? You can see that actually their hip is in extension, then their hip is in extension. You can just imagine that the rectus here insertion as well as the adductor insertion here is pulled, is stretched, and then suddenly they have to kick, right? So they have to activate their core, right? The front abdominal muscles activate, contract, and they also have to contract their adductors because they have to kick across the body, right? So that repetitive kind of flexion extension kind of movement, and you can kind of imagine all the forces, torquing forces that is directed at this region, right? So soccer is not the only one that has this kind of mechanics, right? So other things like hockey, rugby, floorball, American rugby, all have this kind of at-risk biomechanics that many of our patients, they belong to this kind of sport and they come to us with this groin pain. Okay, so there are certain theories described as to what is the pathophysiology, right? What causes this pain? One of it is the strength imbalance between the abs, the rectus abdominis, and the adductors, right? So you can see over here again in the cartoon version, the pull of the rectus abdominis and the pull of the adductor muscles causes a lot of strain at this region. Okay, so it's the relative difference in the strength of the opposing forces exerted right at the pubic region, right, causing pubic bone overload, right? And that also the pull from these two main groups of muscles causes a bit of like a shear force, right? So not only pulling but shearing, right? A bit of a twisting mechanism, if you may, right? And that causes tears at the aponeurosis. Remember this word aponeurosis, where we talked about that fibrous web layer that everything inserts into, right? Everything pulling at different directions, so causes tears at this region, right? Another theory is that there actually are occult hernia. So we thought occult hernia means no, it's not a very obvious hernia. It could be an early hernia, right? And that is contributed from like a weakness or a defect in the posterior inguinal canal. Basically, is in the lower abdomen where there is supposed to be regular musculature. Sometimes there may be a gap or weakness in that, and the intestines actually press against it and actually come out, right? So you can see that this is actually this is what happens in a true hernia. So we're saying that sports hernia is not a true hernia, right? But perhaps in sports hernia, the intestines have not fully herniated out, and it's just an early stage causing these Dow symptoms, right? So this is again one of the theories described as to what may contribute to a sports hernia. Okay, other conditions contributing to the pain symptoms, and again, because sports hernia is a bit like a syndrome, right? It can coincide or coexist with a number of other entities, right? So what Gordon mentioned, adductor tendinopathy or tendon strain, where is this group of muscles, right? So the tendon inserts into the pubic region, right? And this is very near where the groin pain is. So a patient with diagnosed sports hernia may also have adductor tendinopathy and may also have osteitis pubis, right? So osteitis pubis is, if you remember, the fourth entity, which is pubic related kind of groin pain. And essentially, it is actually a stress injury of this region, stress injury of the pubic symphysis, right? I did some bit of inflammation of the pubic tubercle. This is actually a joint as well, right? There is actually like a disc, if you may, in this region. It doesn't really move much, right? It doesn't cause, it's a kind of joint that does not move. But if there are a lot of shear forces, a lot of torquing forces, then the pubic bone is forced to move, right? And if it's not supposed to move and it is forced to move, and that you can imagine how that region can be inflamed, right? So again, osteitis pubis can occur alone. Adductor tendinopathy can occur alone or together with sports hernia, right? So it's important when we examine the patient to look out for all these associated sources of pain as well, okay? And so a bit about history, like how would someone with sports hernia present in our clinic? It's usually a young male athlete, right? Participating in high intensity sport that we mentioned before. Because of the delayed diagnosis, perhaps, something that's gradual onset but worsening, he has observed that his sports performance has decreased over time, especially with explosive action. He can't burst off, he can't kick as hard anymore, right? He can't sprint as fast anymore, right? The pain is mainly over the groin here region or the pubic tubercle here highlighted in yellow, right? And it's usually a gradual weeks to months kind of thing, right? Sometimes it can come as an acute injury, like during athletic in certain athletic sports, right? When there's extreme trunk extension and hip adduction, where there's a stretch or damage to the aponeurosis, and then it can come quite acutely. But most of the time, it is more gradual. It can radiate to the lower abdomen, that means radiate upwards up here to the lower abs, right? Or downwards to the adductor tendon below over here. Right? Again, we mentioned that it can coexist with adductor tendinopathy. It is worsened by sudden increase in intra-abdominal pressure, meaning when you cough, when you sneeze, or even when you pass motion, the increased pressure in the abdomen can cause the dull ache at this groin region as well, right? And hence the theory about having a weak lower abdominal wall comes to play here, right? Where you increase the pressure in the abdomen, and because of the weak musculature, there is more pressure, and hence the pain, right, is being felt, right? When the patient plays sport, especially during movements involving the lower abdomen and adductor muscles like kicking, and we mentioned change of direction, all that, the pain will get worsened. And also when they're doing sit-ups and crunches. Why? Because if the rectus abdominis insertion over this region is injured as well, when you do sit-ups, it will pull on this region, right? So one of the tests that I will show you later on involves sit-ups, right? And if that causes pain, then that is also one of the ways that help us with the diagnosis. Okay, so we go into physical examination. First of all, we have to exclude a inguinal hernia, which is intra-abdominal cause, right? So if it's an inguinal hernia, then this is not something that as sports physicians or perhaps orthopedists or physiotherapists would want to handle, and we will refer them on to our general surgery colleagues, perhaps. Yeah. And so for us doctors, we know how when we examine for inguinal hernia, in the cough reflex, the cough impulse, we feel that there's a bulge in the region, right? And when we have this, when they strain or when they have the cough infects, we can actually feel the intestines, right, kind of sliding into the inguinal ring and coming out over this region, right? So just to explain what these are. So we have seen this before. So this is the inguinal ligament. What is not shown, that's actually the inguinal canal, right? So inguinal canal has many contents, blood vessels, nerves, the spermatic cord in males. And this region actually can also provide a way where the intestines can move from inside the abdomen to come out, right? And perhaps herniate into the testes, right? Into the scrotum. And that's where you have the typical inguinal hernia, right? So first and foremost, make sure that it's not an inguinal hernia, because that can be fixed with surgery, quite straightforward, and there'll be less delay, right, to the patient's downtime, or return to play, right? You can go back to play, go back to sport much faster. So exclude that first. All right. Then examining the hip, right? Of course, we want to make sure that we, as Gordon went through, we have the hip range of motion, or that we shall not go through. But here specifically for sports band hernia, we want to feel for a few areas, right? We feel the conjoint tendon, right? Again, is where along where the inguinal canal, inguinal ligament inserts into the pubic symphysis, right? So point of tenderness of the conjoint tendon, and along the inguinal canal, because sometimes in the cases of a occult hernia, or not a very obvious hernia, sometimes there may be dilatation of the inguinal rings, right? Whether it's the deep inguinal ring or the superficial inguinal ring. So we have to palpate also along the inguinal canal, right? So the surface marking is that, right, is from the ASIS, or anterior superior iliac spine, down all the way to the pubic symphysis, right? So we palpate all this down over here. Also, don't forget to palpate the adductor tendon, the common adductor tendon, as well as the insertion at the pubic tubercle. Okay, this is what we talk about the sit-up, right? So what we call a resisted sit-up. So aggravated during the examination, we do resisted sit-up. So get the patient to do a crunch, and then trying to press him back down, right, to the line, to the supine position, and that should aggravate pain over this region, which is the insertion of the rectus abdominis. Okay, and because we have, it can coexist with osteitis pubis as well as adductor tendinopathy or adductor tendon strain, we want to do the test specific for those conditions as well, right? So we talked about tenderness over this region, right? Adductor longus tendon origin tenderness over here, right? Pain on resisted adduction testing. So we have this thing called the adductor squeeze test, right? So it can be actually done in three positions or three angles, right? And this is the 45-degree angle, which actually activates the adductor longus the most, right? You can also do it when your hips are at 0 degrees flexion and at 90 degrees flexion. Okay, so this is the one that we have at 0 degrees flexion, right? Getting them to adduct against resistance. Okay, and of course we can passively stretch the adductors, right? And also may cause pain along the adductor region. For pubic-related groin pain or osteitis pubis, we want to palpate the pubic symphysis directly. Okay. So moving on to investigations, usually plain X-rays are generally unhelpful for groin pain, but they can tell us a few clues to point us in the right direction, right? First of all, we have osteitis pubis. Again, it's the stress injury of the pubic symphysis, and commonly we see in more severe cases, right, the lysis or the cortical irregularities of the pubic symphysis in this region. Yeah. If you are suspecting adductor tendinopathy and there is some chronicity involved, then there might we also look out for calcific foci over this region where the adductor tendons insert. Okay, but generally not much findings, right? Because this is first and foremost, a lot of it is a soft tissue kind of injury. So bones are quite intact. For those of us who do ultrasound, bedside ultrasound in the clinic, this is not a very commonly done ultrasound region, right? The pubic region. First of all, also because it's something a bit more sensitive to the patient, so that's why it's not so commonly done. But it has been described in literature, and there are certain findings on ultrasound that we can see. First and foremost, over here, you can see that there is when we sound the adductor longus, here you can see that this is an intact adductor longus inserting into the pubic bone. But here you can see that there's actually this big gap, right? This anechoic kind of focus where you can see that adductor longus, the pubic, it may be retracted distally. Okay, so this is a adductor longus tear, right? Then this is not, to be sure, to be certain, this is not sportsman hernia. Yeah. What we may see, however, is things like conjoint tendinopathy, adductor longus tendinopathy, right, or tearing of the aponeurosis along that region. So if I could show you this picture, right? So this is actually a long axis of the pubic symphysis, right? So up here we have the rectus abdominis inserting into the pubic bone, right? And then here we have the adductor longus over here, right? So this is the normal right side, and this is the abnormal left side. So you can see that between these two arrows, this region is less thick, or this is more thick and more hypoechoic in the injured side, right? So showing that there is some injury to that region, right? To give us a further clue, right? But you'll notice that actually ultrasound may have limited use because first and foremost, it is operator dependent, right? However, and also it's not able to, it's a very narrow kind of view, but so very good for a screening kind of investigation, if you may. So most of us do order an MRI to further interrogate the region because it has a wide field, right, and can provide more extensive information within the bone. Yeah. Okay. So here we have it can tell us a bit more of the pubic symphysis and the tendons and ligaments and the muscles surrounding the region. Okay. So over here you will find that this is a left adductor tear, right? So again, to be certain, this is not sportsman hernia, right? So because you can see a big gap. So this again is the adductor longus kind of tear. You can see that it's a big. It kind of lights up. There's the big fluid region edema where they're supposed to be normal on this side, right? So this is the left side, there's a tear, and the right side is intact. So this is more keeping with sportsman hernia. And this is a coronal view, or what we call front view. And this is the side view, or what we call a sagittal view, right? And so looking here, so this is the pubic bone, all right? And we can see that there is actually a fluid cleft at this region where the epineurisis is from the adductor longus is supposed to insert, right? You can see the fluid cleft within the pubic symphysis. The epineumatic plate is kind of lifted off from the pubic symphysis, right? If you may, from the front view. And from the side view, you also can see that here this high intensity signal is white signal, right? This slit is kind of peeled away from the pubic bone, right? For A4B, 5A, 5B from the same patient. So here you can see that the right side has a adductor tendinopathy, and even a high-grade kind of strain. Yeah. Here you can see that the pubic bone kind of lights up, right? With a high intensity focus over here. And this is how perhaps osteitis pubis kind of looks like. And again, kind of highlighting my point that osteitis pubis can also coexist with sports hernia. And here you can see where the blue arrow is pointing a bit of a slit over this region here of the epineumatic plate, again being lifted off. Okay, so my last few slides about management, right? So we're talking about how this injury is actually an overuse injury. So really a period of rest and absence from the provocative sport, right? Whether it be hockey or soccer is very important. This is very simple kind of thing, but it's a very important part of the initial care. So many of times patients who are inpatient to rest and all that, they will take longer to heal from the injury, and then they feel the pain again after a rest for maybe a month, they go back painful again, and they start from ground zero again and have to rest again, right? So most of the time, treatment includes physiotherapy and surgery being the second line, right? However, many professional athletes, because of their time pressures, need to compete on that. They find it difficult to take the necessary 2 to 3 months to rest and to heal, and hence they may opt for surgery instead. Right. So physiotherapy, a course of physiotherapy with rest or relative rest generally takes about 2 to 3 weeks, 2 to 3 months or 8 to 12 weeks, right? With exercises. And what we're trying to do really is to re-establish the function and the strength of the hip adductors and the adductors and the abs, right? The abdominal muscle groups, right? And to avoid excessive stretching because that can give unnecessary strain. Right. So cross training is important, right? So if they are not able to run and able to jog in the beginning, then certain things like maybe swimming, right, with the flutter kick, or maybe some stationary biking may be done as part of cross training, as part of the rehab process. And then after a certain period of time of rest, maybe perhaps about 6 weeks, then gradual return to play, like walking, brisk walking, or even slow jogging can start. Caveat is it should be pain-free, right? And then slowly, gradually progress to sport-specific training and then full sports participation. Okay, surgery is reserved for those who fail a trial of about 3 months of physiotherapy or can't afford the time to the luxury of time to rehab at a slower pace. So there have been multiple surgical techniques described, and for which our next speaker, Dr. Fu, will elaborate on. But what we understand from literature is that there's currently no one most recommended surgery for sportsman hernia. Many surgeons describe mesh reinforcement, right? That means basically putting in a mesh, very much like inguinal hernia kind of surgery over that region to help to reinforce the posterior abdominal wall, right? And many times patients do get a bit better, right? And that further supports the theory about how actually sportsman hernia may have a component of occult hernias as well with a weak posterior wall. Okay, so mesh reinforcement is one of the things that have been described, right? At Dr. Longer's sternotomy is going to be covered later by Dr. Fu, so I'm not too much about it. But we can release the tight adductors from below, and what's above pulling is actually the conjoint tendon or the rectus femoris region. So that also can be a release of those tight structures has also been described before. There are also certain nerves that can be impinged over this region, such as the ilioinguinal nerve, genitofemoral nerve, and by teasing out or dividing the nerve fibers, what we call neuronectomies, have been described also to help to manage the pain over this region. Okay,
so without further ado, I would like to introduce the last speaker of the day. Last but not least, Dr. Foo Gen Lin, our much esteemed senior in this field. So Dr. Fu is an experienced professional with medical training in the UK at Cambridge University and St. George's University in London. So he's a specialist trained in Singapore and in New Zealand. And he's also an accomplished athlete, having represented Singapore at the SEA Games as well. His first-hand experience of sporting injuries coupled with specialist training to treat those injured in u- uh, to treat those in the unique positions, injuries with his experience and as well as his past injuries. He's in a very unique position to actually help all these people, athletes and patients. So Dr. Fu is an empathetic guide for athletes on the journey to recovery. So he also believes in tailoring care plans to each individual's needs and is dedicated to provide comprehensive orthopedic care at the highest level. He's currently working as in private, and he's with the Apex Sports Clinic. So he's a visiting consultant as well to National University Hospital and as well as Kutik,
Woodlands Health.
Kutik
There's
Hospital,
a
I
new
think. Yeah.
hospital as well.
So without further ado, I'll hand over to our esteemed colleague, Dr. Fu.
Thank you, Victor. Very kind words. Thanks, Josh, for inviting, and always a pleasure to be on the same panel as fellow marathoners and fellow allied health professionals. Yeah, last but not least, but I think if you have stayed on long enough for this talk, I'm the part that you don't actually want to see professionally, because it means that physio has not worked, sports medicine has not worked, so you're down to surgery now. So hopefully not. That doesn't apply to the people in this room. So I'll just be talking about the surgical management of the hip and groin injuries that were described previously by Joshua and also Gordon. And again, we'll keep the questions to the last bit. And again, I understand that there's a range of people in this room, from layperson to medical people. So I'll try and keep it as personalized as possible. Cool. Okay, so 3 cases today. The first one will be FAI. Second one will be the external stepping hip on the gluteal tendinopathy. The treatment for these 2 conditions are actually quite similar, at least in my book. So I would lump it together as a part of case 2. And case 3 will be adductor strain and osteitis pubis. So yeah, my general rule for offering surgery to my patients are, if they've failed non-surgical treatment for 3 to 6 months, and they would have gone through a course of physiotherapy, I would have taken well, I don't say bucket loads of medication, but I usually put them on like 2 or 3 types of painkillers to help them with the initial inflammatory phase, make sure that they get through that the painful period and be able to get onto the exercise. Because when they're in pain, they can't exercise, and the physiotherapy becomes a little bit useless in that sense. And also lifestyle things. I mean, not saying that you should avoid stairs all the time, but the initial bit after your injury, you should avoid aggravating your symptoms. And just sports things as well. Like if you're a triathlete, you can switch to low impact cardio like swimming and cycling while trying to recover from running. And I also, like Josh, would offer steroid injections and painkiller injections in case of any patients that have persistent symptoms despite physiotherapy and despite medication. So FAI, I think it was covered pretty well, extensively by Gordon. So not going to go through too much about the diagnosis and the examination. But yeah, it's very common amongst people who have to go into deep flexion, like this guy here on the right. So this can actually really cause the hip to clash against each other. And I think a video speaks 1,000 words. So this is just showing what happens when you have this extra bone called the cam, which is just past that ball part of the hip. So it's a ball and socket. This is the ball. And you can see that as opposed to that nice curve that you get if you didn't have that bone, this extra bone here would jam right onto the rim. This is the labrum, which is a Latin word for lip. So it's just an extension of the bone. It's not bone. It's really like a rubbery structure that provides this seal to the hip. And you really see this illustration of that extra bone there, destroying the cartilage and destroying the labrum as it jams into it. So this is the other type of FAI that Gordon described, the pincer type. This tends to be more in middle-aged females. And the problem here does not lie in the ball. It lies more on the rim side or the socket side. This is whereby the rim is very deep. So normally the rim ends about here, but the rim here is a lot further out. So it really bashes against the neck of the thigh bone or the femur bone, and the labrum ends up being crushed. And the labrum has a lot of pain fibers, a lot of pain nerve fibers, and this is really painful. And the Federer position that Gordon described earlier on is to recreate this particular action. And if it's painful, it usually means that there's something that's going on inside the hip joint. Okay, so the first case was a 41-year-old lady who enjoys trekking. She had been suffering from this left groin pain for years, wasn't getting better despite physiotherapy, despite painkillers. Did not have any trauma or injury, but it was usually made worse by prolonged walking or staircase. Didn't have a lot of medical problems, thank goodness. And Federer was positive. Faber test was positive too. I always test for Baton score as a measure of how flexible patients are, because you do get patients who have hypermobility problems, and this has to be taken into account when we're offering treatment to these patients. And I always do a Baton score because of that, because that could be a cause of why they have hip problems too, on top of the FAI, which could be a red herring sometimes. So she was diagnosed as early arthritis by a few of my colleagues and was offered a total hip replacement, even though that was clearly not suitable for her given her age. But yeah, she came to see me and she was very distressed by the symptoms that she was experiencing when you stopped her from doing trekking. So x-rays are always a good screening tool for any bone problem at the start. So you can see here, I'm just giving you an illustration of what this is her joint. So we measure this thing called the LCEA, which is just a medical terminology for how deep the socket is. So anything from 25 to 40 degrees is considered normal. So she has a normal depth for the socket, how deep the socket is. Anything more than 40 means that it's a very deep socket, and that is what we call a pincer FAI. And in patients, it's very shallow socket, meaning that the socket is like so here compared to a normal hip joint. This hip joint is unstable. It can actually come out with, we don't look after it properly, as you can see on this x-ray here, which is not her case as well. On the right, this is her x-ray that we use to check for any of that extra bone on the femur side, the thigh bone side. I can see that there's this extra bone that has grown here. Not as obvious as this case, which I took from the internet, but you can see what we are trying to look for here is a nice light bulb shape and a nice contour, the sexy curve that you see over on the bottom of the hip. But this is not the case at all on the top part of the hip. That is really nasty looking bump that's just going to smash into the rim every single time this guy goes into deep flexion of his hip. So we went ahead with the MRI scan because that's used to pick up any cartilage issues or any labral tears. And in her case, the MRI showed that she had a labral tear, which is, I told you, the extension of the rim, the rubbery structure that provides a seal into the hip that gets crushed by the cam. So a bit gory here, but it's a keyhole surgery that we do for this. We have moved away from those older technique whereby you actually have to make a long cut and dislocate the hip surgically to get access to the hip joint because it's a very deep joint. We have moved towards keyhole surgery for these cases. And this looks like a torture device, but what we're trying to do here is we're trying to pull the leg to move the ball out of the socket in order for us to work inside the socket. So this is one of the devices that we use during the surgery to perform what we have to do. So inside the hip, this is what that labrum, the extension of the rim, looks like. It's a rubbery structure. And this is the cartilage that lines the socket. And this is the femoral head, the ball in the thigh bone. And this part here would be right inside here, but because we pulled the ball out, so we can get access to this part to do our work. And in her case, when we went in, you can really see here that the labrum is here. And we don't expect to see this frayed edges, which is essentially the cartilage being bashed through. So there's a line that cuts right across here. And this is the frayed edges that you see right here. And this is better seen in this video that shows how this is normal cartilage. We move here, the cartilage is soft because of all the bashing. And this is clearly a tear right through the cartilage. And this is the labrum, the rubbery structure I told you about. Okay, so we repaired the labrum. I just used the illustration from this implant company that I do use occasionally. So the labrum is detached from the rim, or it was really detached before that. We insert this, what we call a suture anchor, which is akin like if you are climbing, you put a peg into the bone, and that's for you to pass sutures through to hook stuff back onto the bone. So this usually are made from high durable plastic, and it stays in the bone. It's not metal, it doesn't cause any problems, and it's inert. So with that suture, that is then passed around the labrum like so, and then it is essentially tied onto the rim to complete the repair. We put about 2 or 3 of these to secure the labrum back into the bone, and the head is then released back into the ball to form that stable labrum that was initially the case. So this is before the repair, and this is after the repair, showing the sutures, and a firm, stable repair was achieved after this surgery. So after the surgery has been done, we have to address the extra bone, which is the cause of the labral tear in the first place. And this is very important because people always think that the labral tear is the only thing that needs to be addressed during the surgery. But if you do not address the cause, because the labral tear is actually the result of something. So in this case, it was the cam that was the cause of her labral tear. And this is now moving out of the hip joint. So we have moved away from the inside. We have moved to this section here. And to orientate you, this is the labrum, the one here. This is the head right here. And the head neck junction is where this bone that we're trying to remove is right here, staring us at us in the face. But it's not obviously as well appreciated because it's a 3D structure. But if you look at it from here on this view on this side, it's flat. It shouldn't be flat. It should be a nice curve going down the neck, but it's not in this case. So we use this very high-speed burr to reshape the bone or sculpt the bone. And this is what it should look like after the osteoplasty or the reshaping of the neck junction. It should look like a nice light bulb. So there's a nice curve going down that is not going to ever hit back against the rim of the socket. And we use x-rays during the surgery to ensure that we do a good job to recreate that light bulb appearance. Right, so that's the first case. And I was glad to say that after about 6 months after the surgery, she was able to return to tracking. I had no further issues with the groin so far. And the last I saw her was about 2 years ago, and she was doing well. So lateral side hip pain can be due to gluteal tendinopathy, as Gordon explained a bit more earlier on. It could also be due to external snapping hip. And it is actually quite common to get external snapping hip that is not painful. I don't offer surgery for these patients because it's not painful. I leave it alone. I mean, I do have my right hip actually snaps occasionally, but it does not cause me pain, so I don't deal with it. I just am very lazy to do my foam stretching and ITB stretches, but that's just me. So yeah, so there are a few modalities, a few imaging tools to confirm the diagnosis, but it's actually a clinical diagnosis for external snapping hip. You just have to put your hand by the affected hip, and the patient normally can recreate that snapping himself or herself. So the surgical treatment for this is to decompress, meaning that because it's a very tight IT band over the bone, So we're trying to release that tension by making a hole in the middle of the IT band so that it doesn't rub against that extension of the bone. Sometimes that could be due to many risk factors like what Gordon mentioned earlier. And there are many different ways of lengthening or releasing the tension. What I do, I mean, they've been described like cruciform, the diamond shape. But what I do normally, I make a circle around the IT band. This is looking at the patient from the side. This is the IT band. This is the top of the patient. This is the bottom of the patient. This is where there's that bony prominence right here, where the IT band rubs against the femoral bone. And this is exactly where I really release it so that it will not rub anymore against the IT band. And this is done through two portals or two keyhole site. This was a 32-year-old patient who unfortunately had a right thigh fracture which was fixed with screws and a long rod down the shaft a couple of years ago. And unfortunately, this one of the screws was actually pretty long and it was really rubbing against this IT band, which, as we know, runs along the outer part of the thigh bone. And these two screws were really rubbing against the IT band, causing him a lot of problems when he was running. So he opted for surgery because unfortunately, not amount of physio is going to take away that screw. So we had to address, obviously, first of all, take out the screws as well as to address the IT band. So this is how the patient was positioned. Those are the two keyhole portals that we made earlier on. And the area of release was, as I mentioned earlier, is right over the crest, which is the part that's most prominent. So this is what it looks like in the surgery if it plays. So this is the IT band. It's actually a white fiber that goes down. So here I'm slowly peeling off the outer superficial layer of the IT band and making sure that I'm working on the right layer and I'm keeping the anterior slip. So the IT band is a longitudinal strip. So I make a hole in the middle, but I need to ensure that the two strips of IT band on the front and the back, they're still continuous because we do not want to cut the IT band completely. I mean, I haven't seen one before, but I think that would be pretty disastrous for patients. Yeah, kind of walking and biomechanics. I've not seen one before, but I don't cut the IT band if I don't have to. So this is after the release has been done, and you can see that the underlying muscle, the vastus lateralis, which is a muscle just underneath the IT band, is exposed here. And if I move the hip in and out until externally rotate, the IT band should be a separate structure from the vastus, and I know that I've done an adequate release. So in his case, we removed the screws arthroscopically as well because we knew that was the offending cause of his symptoms. So on that note too, so this is more for IT band, sternal snapping, gluteal tendinopathy. But if there isn't a gluteus medius tear that is picked up on the MRI scan, I would offer something similar, which is this IT band fenestration or release, because I believe sometimes the IT band presses against the greater trochanter, the gluteus muscles, and there's also inflammation around a bursa. Bursa is a medical term for a fluid sac that's normally within that hip joint to provide a smooth gliding movement to the hip. But sometimes that bursa or that sac of water can get inflamed. And what we do surgically is to remove that sac of water, the bursitis. And for me, at the same time, I do this IT band fenestration or release. Okay, moving on to the third case. Yeah, thanks, Josh, for going through athletic pubalgia. I definitely did not realize there are so many things going on in my pubis. I'm a simple orthopedic surgeon, so most of my work has really been anything below. I don't really work above this layer because we've heard a lot of scary things around here. So, yeah, so I see a lot of patients, usually footballers, as Josh mentioned, is a very high risk factor of cutting spots, and the amount of force that goes through that area when they are kicking and they're accelerating and decelerating. So I see a lot of patients with adductor problems, and that usually shows up on MRI scan as increased signal at the insertion at the pubic symphysis or statius pubis. And again, yeah, there's a lot of forces going through there, and I'm not surprised, yeah, that there are not more of these injuries in the sportsmen. So I'm not going to go through that too much of that because Josh covered that really well, and I'm not going to go through that at all. And they would usually go through a series of physiotherapy exercises to ensure that they don't need the knife if they can help it. It's not a major surgery, but it's again, like I think we know that sometimes the reason for they are getting injured is usually this muscle imbalances, and going for surgery without going through a trial of physiotherapy or strengthening exercises is probably doomed to fail because they're probably going to come back again, and that explains why there's such a high recurrence rate of these injury amongst sports people. Okay, so how I do it, not the most glamorous of position because as Josh mentioned, this is a sensitive area. So patients are usually in this figure of four, they're lying down like a frog, so I can expose the adductor longus, which is that tendon. Because it's called the bikini tendon because if you put yourself in this position, you really feel that band of tendon, a very tight tendon that is pulling on your pubic bone. And this allows us to see exactly what we're doing during the surgery. We then can do this either through keyhole or through a small 2 centimeter cut. This is obviously a very blown up illustration or image of what we do, but in actual fact, it's usually just about a 2 centimeter incision, just right where that bikini tendon is. And what we're doing here is we have to identify the tendon that is tight and we lengthen it so that it reduces that pull on that pubic bone with all that edema and increased signal that you see at MRI scan. And this can be done either through that mini open 2 centimeter incision, or it can be done through the fancy keyhole. But I think, I usually would do it open unless patients request for it for endoscopic, because I find that like if you combine the two keyhole, about 0.5 centimeters or 0.8 centimeters is almost as long as a 2 centimeter incision. So so the main thing with these patients is that because it's very close to the groin, so I do make sure that they keep the area clean, and I avoid like getting them back to sports until the wound is usually healed up in about 2 weeks time. So after that, they can slowly go back to their sports, and I will always encourage them to see a physiotherapist to ensure that they take up good habits to prevent further recurrence of this injury. I think that's my last slide, I think. So thank you so much again, Josh, for letting me speak. And